Thank you very much. And I want to start by acknowledging and thanking the organizers for including adolescents in this important plenary and making them from the beginning the part of the dialogue on the long-acting antiretroviral drugs. These are my disclosures. Why are we talking about adolescents? The adolescents continue to be a very sizable proportion of those living with HIV. And they do not decrease as progressively as we would like to. I'd like to start by celebrating the success. We did acknowledge that we made quite progress in the last decade, 46% decline in new infections among those aged 15 to 24 years. However, we continue to see, and you can see it in the latest UNAIDS report from 2023, just released this month, that we have around 4,000 new infections in adolescent girls and young women under the age of 25 each week. Some countries have made really good progress, and I want to acknowledge those from the report, particularly in infections in young women, and those include Uganda, Tanzania, Zambia, Mozambique, and South Africa. So really great to see that. However, as of 2020, we saw approximately close to 2 million adolescents 10 to 19 years of age, and this does not account for the older youth under the age of 25 living with HIV, accounting for 5% of those living with HIV globally. And adolescents constitute double the number of new HIV infections. I already mentioned adolescent girls and young women. They are the largest proportion of new infection in these populations across the majority of the regions in the world. If you look at the bars, you see predominantly yellow color, and these are the girls 10 to 19 years of age compared to the blue color expressed in the males. We also know that they have lower ART coverage. Only 59% received the ART in 2021 in the age cohort of 10 to 19 years. And we also know that the virological suppression in this population varies greatly, usually quite under 90%, and ranging as low as 27% in some regions to 89%. And we know that as we start them on treatment, they progressively decrease viral suppression. And those of us who take care of perinatally infected adolescents know that it's heartbreaking to see a young person who has been suppressed, quite well suppressed for the majority of their childhood, reaching the age of 13 years, and suddenly you start seeing viral blips once, twice, 3 times, and the viral load goes up. This said that already Claudia did a beautiful job walking through this, so I just wanted to look at the array of the long-acting formulations that we are considering for use, including oral, including injectable, implantable, microarray patches, and non-ARV agents. However, I'd like to also mention an important other venue, particularly focusing on adolescent girls and young women, a combination products of long-acting ARTs together with the contraceptives. This is a real need for these products, and a lot of work is being done in this field. I'm part of the Pediatric Antiretroviral Drug Optimization Group working with WHO, and we gather regularly where we update the list of desirable formulation drugs in the pipelines, creating the timelines for different formulations for pediatric and adolescent use. And here you can see the heat map, and at the bottom in the red box you can see adolescents. In this heat map, we took 4 major categories of the long-acting drugs, and we looked at desirable qualities of those drugs, specifically for adolescents. The major considerations are the adjustment dose capacity, and for adolescents, if you look at the microarray patches, probably would be larger size or multiple that can be put on, but that might be problematic as well, because you all know how the adolescent generation dresses today. There's very little skin covered. So if you have patches all over you, they will become very visible. There are also issues of tolerability, acceptability. It needs to be easily administered and needs to be easily removed when needed to be removed, and capacity for discrete use. And again, if you look at this table, I already mentioned microarray patches. For subcutaneous, we know that they're already working in adolescents. We're already have quite a bit of years of experience. We know that the pain threshold is less. Adolescents, despite being very brave and wanting to fly to the moon, usually do not like needles. We also know that acceptability for this pathway probably will be better. For intramuscular, which we already have, and I will be talking about experience in my clinic in Washington, D.C., less painful would be really important. And then for implants, dose adjustment probably will not be needed. However, we do need to address address multiple other challenges that Claudia so nicely presented. Well, let's go quickly and look, do adolescents actually want long-acting, injectable, implantable, and other formulations? This is a study from the United States, from 3 different geographic areas and 4 clinics. 2 clinics are located in the same area. And this study, like many others, has been done in the era preempting the approval of this agent. So it is in the era where they are not available, they are not advertised, they are not approved. However, that was a survey of 303 youth. Majority of them represent the epidemic in the United States, Black, African American. You can see large proportion non-perinatal, and only 60%, which is going along with many clinics, virally suppressed. They were asked about the interest in long-acting injectable intramuscular ARVs. And you can see the kind of reddish brown bars are pretty high. It is desirability for this and interest in this was rather high. Again, this is hypothetical use, way above any adult studies that we have seen in pre-approval eras. So basically all of them are above 80% and a couple of them are above 90%. When you look at the blue bars, that was the frequency. They were asked whether they would be accepting them based on the frequency of administration, and the lowest bar are for once a week or once every 2 weeks. But once you go in a monthly, I was surprised to see there was no huge difference between once a month, twice a month, or 3 times, once a month, every 2 months, and every 3 months, the difference is not that big. Where I'd like to draw your attention is who wants that. The investigators did a beautiful job by stratifying the responses by the viral load suppression. And not surprisingly, those who had a high detectable viral load, above 1,000 copies, were the cohort of adolescents who mostly desired the injectable, the solution to the adherence barriers. Well, do adolescents think the same across the world? This is a study that just published by Ilona Toska and her team from South Africa, which surveyed close to 1,000 adolescents about the preferences pill, injectable, or other long-acting formulations. Again, hypothetical study conducted 2017-2018. You can see the preference for long-acting that were not pills was quite low, 12%. In multivariate analysis, they identified 6 factors that were associated with preference for long-acting. Those included experiences with medication stockouts, side effects, pill burden, past year treatment changes, HIV stigma, and recent ART initiation. And in a modeling, in the study, 66% of adolescents who experienced all of these factors and challenges were likely to prefer ART. Well, what kind of studies are going in adolescents? Because it is already, drugs already approved. MOCA study, and results to my knowledge are very close to be published, was a study by Impact Network, and it looked at initially introducing just a single injection of cabotegravir oral pivirine with optimized oral backbone, and then transitioned in offering the full treatment regimen with both drugs. Conducted a study in 155 youth enrolled in the United States. And this study actually looked at qualitative research and conducted questionnaires in adolescents, number 23, who received at least 3 injectable doses, and among the caregivers in desk interviews, and some adolescents. And obviously, all of them pointed out to advantages: not having to remember to take pills, avoiding the stress of monitoring adolescents. This is for us, for the parents, and it is a huge stress when they do not take the meds. Not having to worry about hiding pills from peers. But there was a concern. A concern was the ability to maintain routine injection schedule. Remember, those with multi-drug dispensing in resource-limited settings in our clinics, they don't come to clinic every 2 months, every month. They come to clinic every 3, every 6 months. So that would change the schedule of the follow-up. In January 2021, long-acting formulation of cabotegravir and rilpivirine were approved for biologically suppressed, starting at the age of 18 years and with oral lead-in and monthly injection. But rather soon, in February 2022, long-acting cabotegravir were approved for ages starting at 12 years and with a weight of 35 kilos. Oral lead-in became optional, and you could now give it bi-monthly. Well, the eligibility criteria are challenging for adolescent populations. No history of treatment failure in US guidelines, at least 6 months of viral suppression, no known suspected drug resistances, and are we talking about resistance to rilpivirine, where a lot of adolescents with perinatal infection globally have been exposed to NRTIs and have an NRTI resistance, no HBV infection, but very importantly, accepting 2 shots going in your buttocks every 1 to 2 months, and agreeing to come with this frequency to injection point. And another long-acting that is now approved starting at the age of 18 at adults is subcutaneous formulation of lenacapavir, and all of us have extremely limited experience in clinical care yet to use it. Well, an impact MOCA study, which I already mentioned, I will not go in detail of it, but there is another study that's open label non-inferiority study that started recruitment. And these studies are looking under age of 18 as well for 12 to 19 years. And we are looking to see the results that will compare long-acting rilpivirine with oral DTG3TC and TDF. Well, is it easy to find eligible use with all these criteria that are listed, virally suppressed, etc.? So I actually looked at my clinic data in Washington, D.C. It's very similar, but here are the data from the Great Britain. British HIV Association published this data recently. They looked at the cohort of 121 adolescents in the care. Median age is 20 years. And you can see that 21% were under age of 18. And they looked whether they would meet the eligibility criteria for long-acting rilpivirine. You can see that 40% were ineligible, primarily driven by the resistance mutations presence. And second cause was a high BMI. And there was also HBV co-infection there. But even out of the 60% that were eligible, when they broke them down, 41 of those kids met all eligibility criteria, and 2 of them were established already on the drug. However, 31 would require a multidisciplinary team risk-benefit assessment because there were concerns for adherence, for BMI being borderline and possibly moving in a higher range, previous side effects within an RTI and historical periods without ART with no documented resistance. So basically asking, will they be able to stay engaged in care? And in the second half of my talk, I will move on discussing the experiences I had as a clinician and a provider in my clinic. At Children's National Hospital, which is located in Washington, D.C., we have rolled out injectable program in September 2021. It took us 9 months to set it up in the resource-rich settings, including learning a very complex insurance approval process. The drugs are expensive, and also completely changes the way that our clinic is operating. We have never done injections, so we needed to create injection time slots on the schedule. We do not dispense drugs in our clinic, so we would obtain the medication in an outpatient pharmacy downstairs. However, because we administer medications in the hospital settings, we need to be able to track down the side effects, any possible complications. We have to register the dose within our inpatient pharmacy. So just think about the time investment. We had also to train all our nursing personnel, fantastic nurses I work with. They actually do the majority of clinic work. And I want, by taking a moment in my speech, to acknowledge an immense contribution of nursing staff to the fight against HIV epidemic. Without them, our work would not be there. And all of them were experienced with injections, but cabotegravir injection is a deep intramuscular injections. They requested training. We did training online. We did training in person. We also needed to create a database so we can track this 2 weeks window period. The patient needs to come in either a week in advance or a week after the last injection. So we needed to recreate completely our clinic schedule to make sure, and we track them in a separate database than we track any other patients. We started right away to monitor the duration of our injection visits, and we developed individualized plan for each patient, how to manage if the doses are missed, what to do. Drug-drug interaction plan needed to be in place, as well as one of our first patients on injectable treatment got monkeypox and required increase the dose of rilpivirine while being on injectable and being treated for his secondary other infection. And finally, we started our patients. It was difficult, and I do want to acknowledge some of clinic staff were very reluctant. and where some level of mistrust that we've seen. We now have 18 patients who have been, and the longest patient has been for 20 months. We had one patient who started oral lead-in and then refused. We had 3 out of 18 patients now with more complex history, significant obesity, and renal issues, and 4 patients with intermittent viremia, which I will talk on the next slide. And 2 patients, in fact, our first patient developed quite a serious adverse event that is described in a drug inserted associated with potential rilpivirine getting intravascularly. It's quite significant clinically. It reminds you a little bit of anaphylactoid shock. It's not that, and it self-resolves after a few minutes, and it doesn't reoccur. But nevertheless, it was somewhat a stress for the clinic to see that, and I must acknowledge the young man who, despite this reaction, said, I'm coming back, I will do this injection again. So I mentioned the transient viremia. We published letter to the editor. We're describing 3 of our first patients, and then since then had number 4. The 3 first patients in the clinic who went after years of being suppressed on oral treatment have shown one of them had very small viremia under 100, small blips, I wouldn't probably call this viremia yet, small blips on oral lead-in, still went on injection, and then had one serious viremic episode over 1,000. Another one had very small viremic episode of 108 copies, and another one had very small episodes of viral load under 50 during loading dose, and then at some point 869. So why are we seeing this? I don't know. Are we measuring viral load too frequently? Possibly, because we measure it every injection, and we started them on injections at monthly. We don't measure routinely our regular patients every month. We obviously were concerned. We were able to obtain resistance data on 2 out of 4 patients and showed no CAB or rilpivirine resistance, and we continued in a shared decision-making all of these patients on injectable therapy. Each one of them was given an option to reconsider. We had long discussion with them, and in a shared decision-making and after consultation with them, drug manufacturer, we switched those who switched to bi-monthly to monthly injections and agreed that we will keep them on monthly injections for 6 months, measuring viral load on each injection. And then if they're 6 months undetectable, we will switch them back to bi-monthly injection. I'm happy to tell you as of today, out of 4, 2 patients went back to bi-monthly injections, and none of them have discontinued the drug. But it raises important questions for patients who used to come every 3 to 6 months to clinic, now coming for injections. How frequently should we monitor them? And the different guidelines right now are being shaping, and I don't think anyone knew directly the answer, but it definitely becomes a part of the equation, particularly when talking about adolescents and a duration of the visits. As I mentioned, the duration of the visits was quite long in our clinic. Our first visit was, first injection took 1 hour, 45 minutes. I'm happy to see we're now under 30 minutes. As you know, adolescents are much more impatient people compared to us, and they do not like to wait. And here I gathered with the permission of my patients anonymously. By the way, this is our clinic and one of our quality management retreats, so without them, this talk would not be possible. But I just will read you some of these quotes, really inspirational. I like injections because I do not have to think about taking the pill each day. And this is about those who have been suppressed on daily pill for 13, 14, 15, 19 years. I tried oral pills and decided the injection will not work for my busy college classes and activity schedule. I decided to go back to my daily pill. This was the patient that I mentioned before who went on oral lead-in and then reconsidered going on injectional, taking in consideration moving to college and having this as a barrier to schedule for injection. Even though I have experienced this reaction, I will be back trying this injection again next month. As I mentioned, our first patient and another patient who had similar reaction were very resilient, teaching us another lesson about the strength of the young people and their spirit. The shot is not too bad, especially when you have had it a few times. It only hurts for a little bit. And by the way, I did mention that all our adolescents had a normal BMI, and a couple of them were very skinny girls. To tell the truth, even approaching them for injection discussion made me a little bit worried because they are very, very well built, absolutely gorgeous, but very skinny. And I was wondering whether the intramuscular injection would be something they would consider, and they went on and doing quite well. Daily pill worked for me for many years, but I was ready to try something new. I'm glad I did. And this is for those skeptics who will say, oh, if daily oral works, don't bother. Why to even offer them that? I think this quote by this young man is probably the biggest argument why. My visits for shots are getting less timely, and I like it. And finally, for one of the patients who had a viremia that was significant in the southern range, for him, he practices U=U with a dedicated partner, and he's saying, because I had detectable routes, I want to get shots every month to stay undetectable. So this is one of the two patients who at the moment is still not desiring to transition to bi-monthly and decides to stay on monthly injections. So as I wrap up my presentation, I would like to say that I like the title of that session. It is a game changer. We will never go back to just oral ART era. Even the most significant skeptics realize that we're in a new domain, and I agree with my previous speaker, with you, Claudia, that it is changing the way we treat this disease. We're in the very early stages of this. I'm a pediatrician. I always look at trajectory from toddler, first steps. How do you draw the first human figure with just a circle? So I think we're in the early stages of clinical practice of long-acting, but it's definitely here to stay. It does provide a unique opportunity to optimize care and treatment, specifically for adolescents who are known to face multiple adherence challenges. It offers several major benefits, and I'll just mention a few: increased confidentiality, decreased stigma, and improved adherence. However, there are still many questions that we don't have an answer for. We need to know how they will accept it. We need to know it across global settings, not just from few countries. And we need to know whether they are interested in combination formulations. I do want to mention there is an adolescent trials network protocol in development, and another study that started already looking and surveying particular adolescent young women about desirability and acceptability of eventual PrEP formulation together with contraceptives, but for ART is equally important. And in our clinic, we're already doing injections for depot together with the long-acting ART. So that modality is already there. We just have different formulations. It would be wonderful to have them in one formulation. And what is the best implementation strategy? We still have to decide, will adolescents want to come to clinics? In many surveys and many focus group discussions, they express interest for self-injection. Are they capable to do that? Are we capable as a healthcare system to work around their schedules and deliver injections where they want to have them? Can they go in a private space on a college campus and have injection done there? And sustainability, as I mentioned, the patient in our program so far who has had it the longest 20 months, will all of them stay that long period? We are talking about pill fatigue. Will there be injection fatigue? So we don't know these questions yet, and we need to learn them as we continue our implementation and move forward. And I want to finish by saying that you cannot develop these products and you cannot develop the plans to implement them and roll them out without meaningfully involving adolescents and young people. Those who experience these drugs, those who never experienced these drugs, those who have brother, sister, partner, those who just have an opinion. Their opinion, their thoughts are crucially important. And another important element is the real-world data. I shared with you today not a clinical trial, which are fantastic and gave me opportunity to do what I do in clinic, but I shared with you the data from real life. And this implementation work, in my opinion, particularly adolescents, need to really gear at gathering directly their feedback from the first day of injections, from the design of the clinic. And I hope that we will have what you mentioned, Claudia, once a year injection would be probably the most desirable. And look forward to new and more exciting news coming on from long-acting pipeline, but with a focus for adolescent populations. Thank you.